Welcome to your online lecture for Chapter 25, which is entitled Musculoskeletal Injuries. I'm super excited about this portion of the online lecture because it's really what I do as a clinician on a daily basis. Injuries to the muscles and joints and bones are some of the most common emergencies that you as a first responder will encounter in the emergency field. They can range from strained muscles to sprained ankles to more life-threatening like injuries like, let's say, a compound fracture of your femur. Regardless of whether the injury is mild or severe, your ability to assess your patient and to provide the appropriate emergency care can help prevent permanent damage and disfigurement. You remember or you recall from our online lecture on Chapter 5, which is entitled Human Body Systems, that the musculoskeletal system is made up of 206 bones and over 600 muscles. And together, the bones and the muscles of the body really work together to give the body its shape, to protect its internal organs, and to provide movement for us as human beings. And so anytime bones and or muscles are injured, one of those functions is either temporarily or permanently impaired. And so we have to figure out how to assess that and how to care for that as efficiently, as quickly as possible to reduce the chances of permanent damage. So bones and muscles may be injured in four, and I've kind of broken it up into 5 different ways. And so those 4 or 5 different ways, the first one is what we would know as a strain or some type of injury to a muscle and or a tendon when it becomes extended. The next type of injury is a sprain, which is an injury to a joint and a ligament also being injured. And then we have the 2 that I kind of lumped together, which are the dislocation and or the subluxation. And when we think about something that's dislocated, what we're saying is that the bone basically has been moved out of its normal position. And then last but definitely not least is a fracture, or what some of us would call a broken bone. And so these are typically the 5 different ways that you could sustain injury to the musculoskeletal system. And we're going to talk about each of these injuries specifically and how to care for them as first responders. So now that you guys are on your way to becoming health care clinicians, I think it's important to differentiate between strains and sprains, which we'll talk about on the next slide. But a strain is an injury to a muscle or muscle groups or a tendon, okay? And it is not an injury to a ligament. So when we describe a strain, we should always describe it as being injury to a muscle and or a tendon. And so that is what a strain is. What are the signs and symptoms of a strain? There are multiple signs and symptoms that may or may not be present. Some of the most common ones would be pain over the injured muscle and or tendon. We could have dots where we have deformity, open injury, tenderness, and or swelling. We could have decreased range of motion at that joint, or decreased strength in the direction of movement if a muscle is injured. We definitely would get some pain with what we would call active contraction and passive stretch. And then edema is just a nice way to say swelling, a medical way to say swelling. So how are we going to assess the type of strain? One of the special tests that we would use is by method of palpation, or palpation meaning to touch our patient and figure out where exactly they are injured. Then we would do a range of motion assessment and a strength assessment as well to determine how injured that muscle or tendon is. And then if a patient truly does have a strain, what we would say is that they would have pain with active contraction. So that means, for example, if we have a quadriceps injury, the patient would have pain when they move their leg into extension, and they would also have pain when we as the clinician move their leg into knee flexion, which would be stretching that muscle. And that would be a telltale sign that a patient has a strain of a specific muscle. So how do we grade strains, right? All strains really can occur on a continuum, with a grade 1 strain being something that is just lightly stretched. So when we say someone has a grade 1 strain of their quadriceps muscle, what we would say is that they just lightly stretch the muscle. If they have a grade 2, then there's actual tearing in the muscle. And then you could have a grade 3 patient who presents somewhat like this, where there's actually a deformity and you get a large and complete tear of the muscle group as a whole. So we said that a strain is an injury to a tendon and or a muscle, and then on the opposite end of that spectrum would be a sprain. And so a sprain is an injury to a ligament and or a joint capsule. And so we think about a ligament. The major role of a ligament is to hold a bone to another bone. So for example, if we look at the MCL or the medial collateral ligament, it's going to hold the tibia to the femur bone, right? And so ligament job is to provide joint stability. And so when we have ligamentous injury injury or a ligamentous sprain, it really creates instability within the joint that it's containing, or the two bones that it's holding together. And so what are some of the signs and symptoms associated with a joint sprain? Those signs and symptoms include pain in and around the joint or at the attachment sites of the ligament itself. You get effusion and or edema. So effusion is swelling within the joint, and then edema is swelling within a muscle or a tendon. So what we're saying basically is that with a ligamentous sprain, you get swelling within the joint, but you also could get swelling in the surrounding structures as well. After effusion, you get some discoloration, specifically more so with your grade 2 and your grade 3 sprains, which we'll talk about on the next slide. Definitely some decreased range of motion and strength associated with the joint that the ligament is maintaining. And so this list could be more exhaustive, but these are the 4 most common signs and symptoms associated with a sprain of a ligament. But you also get other things like in your testing, your patient will be tender to palpation, so either at the attachment site proximally or distally, or in the mid substance of that particular ligament itself. Your range of motion test and your strength test will be positive, so a patient might have less range of motion due to the effusion and edema in the area, and they also might have decrease in their strength, the strength specifically associated with the joint that is compromised. And then last but not least, you get positive ligamentous stress test, and you'll kind of go through this in KPE 280 with Dr. Sullivan, where you're learning, and also Dr. Gans, where you're learning to stress test different joints to determine the integrity of the ligament. So just like your strain classifications, we also have sprain categories or classifications. And so we think about something that's a grade 1 sprain. Basically what we're saying is that the tissue has been overstretched, right? And so this bottom figure down here kind of represents that continuum where you get stretching of the ligament, but there is no tearing of the actual fibers of the ligament. With a grade 2, you get some tearing of the fibers associated with the ligament, and then a grade 3, you get a complete rupture and maybe even an avulsion or a tearing away of the ligament from one of the bones. And so if we kind of look at this picture here, what we're saying is that this would probably represent a grade 1 where we're getting some stretching of the ligaments, this would represent a normal MCL here, and then this would kind of represent either a grade 1 or a grade 2 where you get micro tearing, and then a grade 3 would obviously be a complete rupturing where those ligaments, as you can see here, are completely torn, right? And so grade 3 would be a completely ruptured or avulsed tendon. Your grade 2 would be there's some tearing right in the mid substance of the ligaments, and then this is probably more of a normal, maybe a grade 1 ligamentous sprain. And so we can get an appreciation for why a stress test might be more positive with a grade 3 and why you might get more opening of the joint line in a grade 3 ligamentous sprain. Typically, it's because that ligament is no longer intact. Another common injury that we might see more so in athletics, sometimes in an emergency situation, depending on the emergency that we encounter, are fractures. And so we can see down here in this figure below that this patient has fractured his tibia and his fibula bone. And so we got to talk about, what are the signs and symptoms of fractures, because some fractures might not be as obvious. And so some of the common signs and symptoms associated with fractures, specific fractures of this type, number 1 would be deformity. If the fracture isn't completely through the bone or a compound fracture, you might have pain over that particular bone to touch. Your patient definitely will have decrease in range of motion and strength, decreases as well. You might get some swelling if the fracture presents like it does here in this figure below, then for sure you'll have the rapid and profuse swelling. And then last but not least, you probably will have some discoloration and or what we would call ecchymosis associated with the fracture. So when we talk about the severity of the fractures, if the fracture does not protrude through the skin, if it's not compound in nature, then you're not really concerned about blood flow compromise. However, if you do have a compound fracture so a compound fracture that looks like this, one thing that you're concerned about is whether or not you're going to sever any arteries. Specifically, in this particular injury, we might have severed the tibial artery. We might have severed the fibular artery as well. And so we want to make sure that all of our blood supply is intact and that the blood vessels are intact as well. If we do suspect that an artery has been severed, then that is a medical emergency. We're calling 911. Otherwise, your treatment really is going to be to splint, right? And so how do we test for fractures that are not this obvious is the question. So the number one way we can test for a fracture is palpation. So the site will be completely painful to touch. Your patient might jump off the table. Another way is through percussion. You guys kind of probably already learned this in Dr. Gans's 280L or 280 lab, where you're going to compress the bone or you can tap the heel to see if you can get any vibratory forces going up the kinetic chain. You can also compress at the site and or above and below the fracture site to get pain. And then last but not least, you can do use something that would cause vibration to go up the proximal or the kinetic chain, and that would be a tuning fork. We'll do that in lab, and I'll bring in a tuning fork so you can actually see what it's going to feel like. So this figure below would represent a compound fracture. So what is a compound fracture? A compound fracture occurs when the bone actually protrudes through the skin. And so what we see here, if we're looking right at this bone here, is that this would represent our femur bone. And our femur, in this case, has completely fractured through the quadriceps muscle. And because the quadriceps are such major knee extenders, what happens is once the bone protrudes or once we have a compound fracture, those quadriceps contract and they actually make the femur bone or pull the femur bone distally. And so it poses a different problem for a first responder in an emergency, in that typically we would splint this fracture. However, with a compound fracture of the femur, we actually have to apply traction to overcome the compressive or contractile forces of the quadriceps muscle group. Another common medical emergency that you might encounter in the musculoskeletal system would be luxation or a subluxation. And remember, we define luxation as a bone coming out of its place and staying out of its place permanently until it's actually relocated. And then we've also defined subluxation, which is where the bone comes out of its socket and then goes back into its socket spontaneously, so it doesn't require anyone with medical expertise to relocate it. The onset with either a luxation and or a subluxation is typically acute in nature. Either the patient sustains a blow to that limb or they're rotating and pivoting on a foot like this patient here, where we see the foot, the entire tibial fibular joint or tib-fib joint has completely dislocated and turned or rotated into a posterior fashion. So most times luxation and subluxations are going to be acute in nature. However, they can become very chronic. So let's take a person who initially subluxes or luxates their joint, right? And they have it relocated, and because the tissues surrounding it have been completely stretched, they now have subluxations or suffer from subluxations chronically. So an acute injury can lead to chronic subluxations because of chronic joint laxity. And so some of the common signs and symptoms, specifically more so with a luxation than a subluxation, would be a gross deformity where you actually can see the bone sitting outside of the joint itself, and then the patient probably would have severe pain and an inability to move that specific joint because once a bone moves out of its place, you then lose the ability of the joint to function as it normally would. So how do we specially test for a luxation or a subluxation? Well, we said with a sprain, we're going to do ligamentous testing. However, they're contraindicated in a patient with a luxation. And the big reason is because once the bone is out of its socket or the joint is displaced, one thing that we don't want to do is put it back into place and subsequently either sever an artery, a vein, or any other type of blood vessel. And then we want to make sure that we always check a pulse in a patient who has a luxated joint or bone. And the big reason is because we want to make sure that there isn't any impingement or rupture of the nerve or the artery supplying that particular joint. So we always want to check a pulse that is always distal to, and so in this particular situation where we have a complete elbow dislocation, you'd want to check the radial pulse on this patient. If we had a hip dislocation, we would want to check either the femoral pulse and or the popliteal pulse distal to that particular injury. If you notice that there is a lack of pulse or that their pulse isn't within normal limits, that's a medical emergency because that means that blood supply is being compromised to the distal extremity. And if you have a major joint dislocation, more specifically, the elbow joint is one of the major joints that we want to refer to an emergency room. The big reason is because of arteries and vein and the major blood supply that flows through the cubital fossa in the elbow joint. So anytime you have an elbow joint dislocation, it's a medical emergency. Anytime we have a hip dislocation, it's also a medical emergency, again, because of the major blood supply. And last but not least, anytime we have a complete knee dislocation, not a patellar dislocation, a complete knee dislocation, that's also a medical emergency, again, because of the blood supply that runs within each of those three joints. So the question becomes, how do we as first responders care for injuries such as fractures, luxation, subluxation, strains, and sprains that we might encounter in an emergency situation? And I think these 6 rules, if nothing else, always apply. And the first thing that we want to do is, if we encounter an injury that is bleeding out, the first thing that we want to do is we want to stop the bleeding. And that's the first thing we want to do. And so we can do that by applying pressure over the wound as long as it's not painful to do so. We can also do this by applying pressure to the proximal artery that would be supplying that limb. And then if it's an open wound, we want to cover that wound. And the reason we want to cover it is to avoid infection. After we've covered the wound and we've stopped the bleeding, the next thing we want to do is to care for any life-threatening injuries first. And so when I say life-threatening, I mean blood that might be squirting from a wound, a compound fracture where the bone might be exposed. We want to care for those injuries first. And then next, what we want to do is apply some type of manual stabilization above and below the injured site. And we'll talk about that a little bit later in the next few slides that we will be discussing. If the injury is closed, you can apply ice. Ice is good for reducing pain, but not only for reducing pain, but it can also help impede or reduce inflammation as well. If you determine that that there's a fracture to the injured limb, or you think that the injured limb is subluxed or luxated, or then in that case, what we want to do is we want to splint the wound, and we'll talk about the process of splinting in the next few slides. And last but not least, if we do apply a splint, or if the patient is bleeding through the wound, and we want to check a distal pulse. And the reason we want to check a pulse is because we want to make sure that the patient is receiving blood flow to the site. And so one thing to always remember, someone said it best, is P, M, and S. And P would be the pulse. M would be the movement, as in motor, so things that they could do. And then last but not least would be sensation. So when treating musculoskeletal injuries, specifically when we splint musculoskeletal injuries, the first thing is we want to apply body substance isolation precautions. So our gloves, our gowns, our mask, and that's truly going to be dependent on the type of wound that we are dealing with. Another thing is that we do not want to release manual stabilization until they are completely immobilized. So what do I mean by that? Once the splint is on, once we've applied the splint and the splint is secured to the patient, then and only then can we remove our hands from the patient. Never replace protruding bones. So one thing that you don't want to do is try to put that bone back into its position. One rule of thumb is always to splint the injury as it lays. So when you see the patient in a supine position with their arm and the bone is sticking out, we never want to try to put that bone back into place. In doing so, what we could do is injure the blood vessels that supply that actual joint and or limb. So one thing that we also want to do as first responders is assess. You want to assess the patient, right? Well, you can't assess what you can't see. And so one rule of thumb is, as you can see in this figure, both here and here, is to expose the injured limb, right? So if you have a pair of shears, which this person does, you can cut the patient's pant leg or sweater to get, or sleeve to get to the arm. Obviously, we want to maintain the patient's privacy. So if it is a female, we never want to just completely cut off the patient's shirt without having some type of blanket or something to cover them up with. And then last but not least, again, kind of repetitive from the other slide, but we want to control bleeding prior to splinting. So rule number 1, control the bleeding first. Rule number 2, stabilize. And then rule number 3, we would be splinting. So now that we're into splinting of musculoskeletal injuries, I think that you have to know the following rules in order to splint correctly and to make sure that the joint is completely stabilized. And so if the injury occurs to a bone, so again, a bone, so the femur, the tibia, the fibula, so if it's to a bone, we want to immobilize the joint above and below that. So let me give you an example. If you have an injury to the tibia, you need to make sure that you've splinted at least the femur and the ankle joint or the ankle in order to make sure that that bone is stabilized. If you have injured, let's say, the radius and ulna, then you need to make sure that the wrist joint and the elbow joint are stabilized. And so those are two examples. On the opposite end of that spectrum, you can also have injury to a joint. So if a joint is injured, we need to immobilize the bone above and below it. And so a prime example would be the ankle or the ankle joint. If you injure the ankle joint, you need to splint the toes and the tibia and fibula. If you injure the elbow joint, then you need to splint the ulna radius and the humerus. And so those are the rules when we're splinting both bone and joint injuries. If a limb is severely deformed or pulseless, then we're going to align it with manual traction. And this holds true for one injury in particular, and as you might remember, the compound fracture of the femur, where we actually have to apply a traction force through the foot in order to reduce the contractile properties of the quadriceps. And so again, this is the only time that we align with manual traction is when we do have a compound fracture of the femur. And then we want to do, again, our PMS, so your pulse, make sure they can, whether or not they can move it, and then you want to make sure that your patient has sensation. It is highly possible that if the splint is applied too tight, so if it's so tight that the patient can't feel anything, that you might actually end up cutting off circulation to the injured limb, so that could be a bad thing as well. One other thing that we can do to assess either pulse and or blood flow is to do a capillary refill. Okay, so if you can't assess the pulse, a capillary refill is a good secondary backup tool. So there are four main reasons that we would splint in an emergency situation. Reason number one is to prevent motion of bone fragments or a dislocated joint. So another way to say this is that if we want to restrict and or limit movement, if we want to minimize damage to surrounding tissues, so let's say, for example, we know that movement of a joint or a bone would cause more damage, then in that case we would also want to splint just to reduce the amount of motion that might be occurring at that joint. If a patient has pain with movement, splinting them obviously causes immobilization, which means they can't move, and so you get a reduction in pain. And then last but not least, if you have to, let's say, move a patient who has an unstable fracture or who is in pain because they can't move the joint, then in that case, splinting would be indicated as well. Now, I pose four different reasons for splinting, but there probably are others. These are probably the four most common reasons that we would splint in an emergency situation. So as stated previously, we want to check P, M, and S, and so remember that's pulse, movement or motor, and sensation, both before and after, right? The after tells us whether or not our splint is too tight, and the before just gives us a good gauge on whether or not our circulation is within normal limits. We're going to apply the splint. Again, rule of thumb, if it's a joint, we're going to splint the bone above and below. If it's a joint, we're going to splint the bones above and below it. And so those are the rules of thumb for splinting. Make the splint tight, but not so tight that it cuts off circulation. Again, this can be assessed with cap refill if you cannot get to the pulse that supplies that actual injured limb and or joint. And then if no pulse is present, applying traction may help. And so again, we're really only going to apply traction to a compound femoral fracture. So if we look at this figure here, what we can see is a traction splint. This traction splint, really what you're getting is, in this corner right here, you really can't see it, is a traction device where it is actually pulling the tibia and the fibula this direction, and then you get traction going this direction, and what that does is it kind of pulls the femur back into its normal resting position. Again, a traction splint only utilized for a femoral fracture, specifically a compound femoral fracture. So for the last part of this online lecture, we're really going to get into specific types of splints for specific types of injuries. In the first injury we're going to talk about is a shoulder injury. This could be something as simple as a shoulder subluxation. It could also be something as simple as an elbow dislocation here. In either event, what we want to have is we want an elbow sling first and foremost on that patient, and we want the patient's arm to be at least at the heart, if not above the heart. Again, this assists in blood flow back into the circulatory system. And so when we think about what types of injuries or pathologies we're going to use a shoulder sling for, the list is limitless, but typically it's shoulder subluxations, fractures of the humerus, the radius, and the ulna, a fractured wrist, or an elbow luxation or dislocation, depending on who you ask. And so these would be these pathologies listed here would warrant some type of splint that looks like this. What you see wrapped around the patient right here is what we call a caravat or a binding sling. So after you've placed the patient in an elbow sling, you'll provide a bind which wraps around the entire trunk to avoid allowing the patient to move into an abducted / flexed shoulder position. So more specifically, when splinting the elbow or an elbow injury, we really want to splint in the position that we find the pathology. And so I give you two different scenarios. The first scenario is here. We envision that we found this patient in a flexed position here, whereas the patient in the lower picture here, we found the patient's elbow and it was in an extended position. And so what I'm saying to you guys is that we always want to secure the elbow injury or any injury in the position that it was found. We never want to move an injury so that it can make splinting easier. We always want to splint it as it lays is the rule. Any movement of the injured elbow or injured area can really cause vascular and or nerve damage. So again, always splint it as it lays. We can use lots of things to splint the elbow. What you see here down below is what we call a SAM splint, which is very moldable to our patients. And then what we see going across the patient's trunk or this white material here are just old sheets that were used to hold the elbow in place. And then this is just they are just pieces of cardboard. So you can be very creative in an emergency situation to create splints based on the supplies that you have. Again, if the elbow is bent, you're going to splint it in a flex position, and if it is straight or extended, you're going to splint that elbow in the extended position. Splint it as it lays, and of course we'll do this in lab when I see you for the next class period. So for the lower extremity, splinting is very similar. It's just in the lower extremity. The only time that splinting is different is, again, if we have a compound fracture of the femur. If we have a compound fracture of the femur, then of course we're going to be using a traction splint. Otherwise, any injury to the lower limb could be we could use two padded cell foams. We could again use we could also use our vacuum splints or our SAM splints. Any other splint can be utilized to splint the lower extremity. Again, remember the rule of thumb for any injury that we are splinting. Joint, we're going to splint the bone above and below. Bone, we're going to splint the joint above and below. If in fact we have a femoral injury here, then we really want to splint from the groin all the way down to the foot if we can, or from the armpit to the foot, and that's a bit extreme, but the reason we want to do this is because we really want to provide as much stability as we can to our joints so that a joint that is injured or a bone that is injured does not have to move or have stresses applied to it. By doing that, then we can reduce pain in our patients, and we can also reduce movement, which again leads to reduction in more injuries occurring at the emergency scene. So when we think about splinting the knee, again, I've given you some figures here just to show you that there are lots of things that can be used. Number one, we have a pillow being used to help support the knee into a flex position. And again, we can envision that this responder found the patient's knee in a flex position. So again, they've supported the knee with some cardboard, and then they've wrapped the cardboard on using some type of sheet. And so again, if the knee joint's injured, we've got the tibial bone being splinted and we've got the femur being splinted as well. So that follows the rules. And then if we encounter a patient who has a knee or the knee is extended, again, we splint the knee in extension. Now, if the knee joint is injured, as we see here, then what we would splint is the tibia and the fibula distally, and then the femur proximally as well. But again, remember the leg is in an extended position. So we always want to, if I could say this again, immobilize in the position found. Immobilize in the position found if we can. Last but not least are ankle and foot injuries. Typically we can use a vacuum splint with this type of injury, or as you can see in the figure below that they've used a blanket. And what you basically are doing, again, if it's to the ankle joint, you want to splint the tibia and fibula proximally and then the toes distally. And so what you're going to do is just wrap that blanket around so that it's nice and tight and secure, and then secure that blanket with some type of sheet or a ripped piece of shirt that you might have at the scene. So it's clear that splinting becomes a very easy task or skill to use as a first responder. As long as you have materials at the scene, you should be able to splint anything. You could use something as simple as a pillow or a blanket to splint, or again a circumferential splint, or what we would refer to as a vacuum splint. And you will get lots and lots of practice with vacuum splints in the lab here at Point Loma. What we tend to use are the vacuum splints. They are typically the gold standard of splinting, again, unless you have a compound fracture of the femur where you're actually utilizing the traction splint. So with all of these splinting techniques and specific splinting techniques, we will go over these in lab the next time that I see you. So this concludes our online lecture for this particular chapter. If we can end with the conclusion, I would say to remember the following things: that if you have a joint that is injured and you are thinking of splinting, you must splint the bone above and below it. If you have a bone that is injured and you are thinking of splinting, then you must splint the joint above and below it. And then once before and after we splint our patients, we have to remember PEMS, that we have to assess both the pulse, the patient's ability to move it, and whether or not that patient has any sensation or feeling within that particular injured joint or tendon or muscle and or bone. So if I could leave you with anything, I would leave you with these 5 rules of thumb for splinting in an emergency situation. This concludes this online lecture. Looking forward to seeing you in class.